at the University of Minnesota. Welcome to the podcast.
Hi, thanks for having me.
Annie, would love to hear more about your work, your research interests, and we'll see the kind of questions and discussions that can lead to. So, would love to hear more about what you do and what interests you.
Sure, absolutely. I work as part of a collaborative group that studies the mechanisms of eating disorders, how eating disorders come to be, how people get stuck in them, and then ultimately how to treat them. And in particular, most of my research so far has been on anorexia nervosa, the disorder where people restrict their eating so severely that they become underweight. And unfortunately, many people go on to become quite medically ill and sometimes disorder. I went to a small private high school, all female school, and a disproportionate amount of people that in that school had an eating disorder, specifically anorexia nervosa. So if you think about population estimates are about 1%, I would say about 10% of my graduating class had the disorder.
And do you have a suspicion whether or not that is a cultural phenomenon? Like,
great question.
Is it just because people sent at-risk youth all to the same place?
It's a great question. I will tell you that there is a tiny bit of research to say that all female environments tend to have a higher rate of eating disorders, and that private schools tend to. So I don't, and so, okay. But I have talked to colleagues who had went to similar high schools that saw a similar manifestation, but it wasn't eating disorders. It was a lot of these hardworking, driven, highly cognitively engaged people being intensely suicidal, for instance, and having a lot of suicide attempts. And so I think it just happened, and it's there may be a gender element to it, of it manifesting in eating disorders in my high school. But I became really fascinated by this because obviously I saw the firsthand devastation of it. So as I went on and pursued my clinical psychology PhD, I started out actually really interested in just learning how to treat this disorder. There's almost no treatment. We have some decent treatment for adolescents, but once somebody gets to adulthood with this disorder, simplifying things, essentially all we can do is put them in the hospital, get them to a healthy weight, and cross our fingers. There's no evidence-based treatment for long-term, positive results for this disorder. It's not that people haven't tried to approach the why question, but they have done it in a way that all the efforts so far haven't really gotten us very far. And part of what I think has limited that is there's a long-standing history in psychopathology research to assume that the way something looks is its mechanism. So for instance, the most standard treatment for eating disorders is cognitive behavioral therapy for eating disorders. It works reasonably well for eating disorders where people binge eat and purge, but it doesn't work very well for anorexia nervosa. And what they think of as the central mechanism, the thing they target in treatment, is body image. Well, to me, body image is a symptom. It's not a mechanism. And I think this is what's really drawn me to more of the neuroscience and translational work is we know so little about how the brain works to get people stuck in this very, very serious pattern that can lead to death. Mm-hmm. And we, I think, keep chasing red herrings in, it's desire for thinness. And it's like, yes, but why? So I kind of sometimes think about the work I'm doing now as sort of like the game my toddler plays of, every time you say an answer, you say, but why? Why? And I feel like over time I've gotten further and further down the why rabbit hole of trying to figure out, yes, we know that this group of people pursues this weight loss, and we know that they value this weight loss, but why? What is it about the weight loss that they value? What's going on at the level of their brain that keeps them stuck on that particular thing that they want to pursue? So that is my trajectory in a nutshell. And I've been lucky enough to connect up with fabulous colleagues at the U who have the same sort of general goal of saying, how do we better strengthen our understanding of psychiatric illness by also leaning on the strengths of neuroscience? So that's where most of my research has started. And one of the biggest questions I've been trying to answer, and our group has more generally, is why do people get stuck in this disorder? Most people in the US, at least, try to diet at some point. Most people try to lose weight, and sometimes actually, like, the general public often uses pretty extreme methods occasionally to diet, things like fasting. But most people don't get stuck in that kind of behavior long term. Most people think it's really aversive to diet. They think it's pretty unpleasant. They, like, as soon as they lose the amount of weight they want to lose, they stop it because they're like, oh, that was unpleasant. But people with anorexia don't. And so a lot of what we've been trying to figure out is what is going on at a neurobiological level and a decision-making level that leads somebody to continually decide to put themselves in harm's way to pursue this goal. And I can talk more about this, if the conversation leads there, but one of the things I've become increasingly interested in as well is, this over pursuit of a societally held goal, which, weight loss, especially for women, is something that society tends to encourage. Are there other manifestations of this in psychiatric illnesses or sort of like problematic patterns in the general population? So one of the things I've been really interested in is is something like work addiction, where people, work addiction, this is not an official diagnosis, but where people work and lose their relationships and affect their health, and sometimes even, literally work themselves to death. Is that the same thing, just attached to a different goal? Broadly speaking, what I'm trying to do is figure out what's going on when somebody takes a goal that most of us want to pursue and just takes it way too far. And how do they get there, and how do we get them out?
You mentioned work addiction. Do we know enough about the two phenomena, the eating disorders and work addictions, to the point of knowing that they're compatible?
My personal opinion is that this hasn't been classified as pathology because as a society, we highly value work, and we tend to call those people, industrious and, and go-getters and whatever.
Of course you mean.
And so, exactly. And so, so we really don't know much about it. And of course, because it's not a diagnosis, it's not funded by most funders. The rigidity in behavior in anorexia can look somewhat like OCD, could look somewhat like autism spectrum disorders, like obsessive compulsive personality disorder. There's all these disorders that have this sense of rigidity and over pursuing this goal over and over and over and over and over again, even though it clearly becomes harmful for them.
Well, I think it's a really good, it's a really good segue, because one thing that, our lab is really focused on is really this idea of transdiagnostic circuit-based approaches. And I think it's hard because from the funding perspective, like you mentioned, we sometimes say, well, we're really interested in, cognition. And so we're interested in epilepsy and Parkinson's and addiction and depression. And from a funder's perspective, that looks ridiculous,
Right.
And from our perspective, it's like, no. if you don't look across diseases, then you're not really doing something circuit-based because you have no comparisons. You know, and we're looking at this sort of pathology. And so I think one thing that a lot of patients don't realize, although it seems very straightforward, is, you know, that there are common mechanisms and common problems across very similar, adjacent, or exactly the same circuits that perpetuate sort of that, you know, erupt as sort of the same pathology.
Absolutely. You know, you're allowing me to step on one of my favorite soapboxes, which is I've tried several times to try to get funding to basically study this idea that the same sort of highly controlled, maybe overactive cognition, overactive executive functioning shows up across many different disorders. And I can't get people to fund it because I always get pushback about, you know, it's too diffuse. There's, you know, different psychiatric disorders are going to have different presentations. And all I know is that in the clinic, you know, people often approach disorders like anorexia nervosa as this niche, very different phenomenon from other things you might see in the clinic. But I will tell you, I've seen the same highly controlled, perfectionistic, hardworking, driven personality show up in the clinic with depression and anxiety and OCD and sexual dysfunction, like across everything you could, any clinical phenomenon you could think. And so I think that's something that can be really frustrating, is acting as though just because something looks different, it must be caused by a different thing. And I think there are only so many ways that decision-making can go awry. And unfortunately, I don't know. I think often we act as though each individual diagnosis is an entity into itself, which it's obviously not. We just created them ourselves as, you know, psychologists and psychiatrists.
Right. It's sort of the curse, you know, the other side of the coin for diagnosis and being able to approach things systematically, you know, whereas if you look at most of the you know, cognitive decision-making community, you know, they're pretty far removed from humans. Not always, but, you know, they're pretty down the pipeline. The people that get to focus on these sort of mechanistic what we would consider to be transdiagnostic things are a little bit up the line. And then on the human side, you're exactly right. It is very challenging to convince one funder. You know, for us, it's between NINDS and NIMH. We're trying to, you know, figure out how are we going to spin it this time so that they think that we're really focused on just this one disease and this one circuit. It's much more difficult to convince them but at the exact same time, there's sort of this big push on the psychiatry side for this RDoc approach and being able to be, you know, interdisciplinary. And I think, you know, the funders are sort of coming to grips with this, but it's still really challenging. You're exactly right.
And I think the problem is, if we don't take a transdiagnostic approach and we do just say, you know, we're studying OCD over here, we're studying anorexia over here, we're studying, you know, depression over here. The problem is, what if something could work for, you know, as you said, if you're studying circuit-based disorders, what if a circuit-based treatment could be effective for all of them? What we currently do in most grants is we say, this grant is about, you know, the mechanisms and treatment of OCD. And so you figure out what's happening with OCD and you figure out how to treat it. And then in the next grant, we say, okay, let's see now in this grant if it applies to, you know, anorexia nervosa. And then we try that. And then it's just the pace of science is already so slow. It seems unnecessary to make that even slower.
On the clinical level, everybody already knows these mechanisms are overlapping, and proving that and, you know, unifying treatment has real effects. You know, there are examples I mean, there are already examples, even on the neurosurgery side, where we say, okay, if your pathology is in this part of your spine, you get this kind of treatment. And if your pathology is in this part of your spine, we will not approve this kind of treatment, even though there's no difference in the mechanism or anything that's going on. And it's just a product of sort of, what's come out in the literature and how people have talked about it. But at the end of the day, the mechanisms are overlapping. And that seems to be what that should be the important part when we're talking about, treatment. We don't want just one drug that's approved for, OCD. We want, treatments that are approved for the circuit pathology that we can find. And that's where we're really trying to head with neuromodulation. Mm-hmm. And specifically, one thing that we talk nonstop about is this idea of cognitive effort or perceived cognitive effort and cognitive flexibility. This is a big part of our push. And, at every moment we're, rolling out studies and trying to do both invasive and non-invasive work. And at every moment we feel like we have no idea what's going on, with this very complex thing where we try to construct these tasks that have, that are relatively structured in order to be able to pull the data out, but also very complicated because of, how difficult it is to really understand this concept, on a larger scale in terms of life.
It's a tricky thing. And I think anybody who works clinically and does, mechanistic research probably faces this where to really well understand a particular mechanism, either behavioral mechanism, brain mechanism, you kind of have to get narrow and really investigate it. And yet, like, anybody who works clinically with patients knows that you almost never just focus narrowly on one thing, that you every person walks in with multiple different sets of pathology or things that contribute to their problem. And then you have to figure out, how do I take a higher level perspective and integrate everything I know from these like smaller, narrow mechanistic studies. So it's really tricky. I think actually that's one of the strengths of a lot of what we're doing at the University of Minnesota is we do have groups that are talking back and forth between people who are more basic and people who are more applied. And it allows us to kind of like zoom out and zoom in, so to speak, about the bigger picture of what does mental health and mental illness look like, and then this more fine-grained picture of, and how does it look in this particular circuit or in this sort of particular class of cells or whatever. I think that's a real strength of some of the work we're doing.
I wanted to ask you a little bit more about your thoughts on this relationship between cognitive flexibility and effort.
Mm-hmm. Yeah.
Well, we struggle with a lot. And in particular, there are kind of two almost completely opposing ways you can look at this. Our running hypothesis is that cognitive flexibility takes effort. Mm-hmm. So imagine that switching, state shifts, exploration, those might be effortful processes. And in many cases, it might be easier just to keep doing what you're doing and not, think too much about other possible options or other potential decisions, and not to go and explore for better choices. On the other hand, persistence itself can take effort, right? And so, sticking with something sometimes is experienced with effortful. And so at a certain point, it might actually be easier just to like stop what you're doing and give up and go do something else. And so this tension is something we really, are fascinated by, and whether or not, just how to think about whether or not we should expect flexibility to increase with people who, are effort driven versus effort averse, I guess, to put it that way.
It's a great question and thought. So Alex has probably heard me say some version of this before, but I think so often the way you're framing it is how we think about these problems, which is, I'm going to very simplify. I know you don't think about it in this simple way, but I'm going to simplify it. Is up bad or is down bad? Is effort, is cognitive inflexibility going to manifest in too much effort, or is cognitive inflexibility going to manifest in too little effort? And what I think is that it's more likely to be a bell curve. That if you think about overexertion of effort towards a narrow goal and relinquishing all effort, I think both could actually come from cognitive inflexibility. Because some of the work we found with people with anorexia nervosa is that they are highly persistent. Clinically, they're highly persistent, right? So they have this goal of weight loss, and they work towards that goal, even once their life falls apart around them because of working towards this goal. And when we give them decision-making tasks, we see the same thing, that they seem to persist towards these same goals. They show on sort of classic cognitive flexibility tests, they show a lot of cognitive inflexibility. And one of the things that we are starting to find from the research we're doing is that it seems in our patients with anorexia nervosa, this seems to be facilitated by a very efficient cognitive process. They do it quickly, and they seem to underutilize some of the brain structures like the ventromedial prefrontal cortex, where you might be resolving conflicts or kind of generating a sense of evaluating the value of something. So basically what we're seeing is they're making very fast decisions using what we usually think of as exerted for more sort of balanced and effortful cognitive control, but it doesn't appear to be a taxing process for them. It seems to actually be cognitively efficient. And I think it's also very cognitively efficient to quit something, you know. It's the in-between. I think that's a little bit more difficult to say, do I exert effort into this? At what point do I relinquish effort because the value isn't there anymore? At what point do I push forward because I think the value might be there in the future? That's a lot more difficult than saying, I'm going to pursue this at all costs, or to say, I'm not going to pursue this, I think.
It brings up a lot of questions about there really being no true optimal solution. You know, there's not a truly optimal way to balance this. You know, you could go through every moment of life constantly reweighing your decisions and constantly trying to figure out if what you're doing is the right thing, or you can go, you know, the other extreme is what you pointed out, where you've already made all the decisions. You're just going to continue to do that and reinforce that. And the ability to, I guess, switch between these sort of two modes. It's like the metacognitive flexibility. There's not a real clear answer to that, because there are many cases where we need either one, you know, or we need both.
And that's probably where flexibility becomes most important, right? Being able to say, this is the right time to use that more efficient, fast-paced cognitive style. And this is the time when I have to think it through a little bit more. And as you pointed out, the way I framed it actually made it sound like the thinking it through is the healthier way. But, you know, you can also have times where you get so stuck in deliberation where that's not effective either. So I think all of this is just figuring out which decision-making system is most suited for your goals, and not getting too stuck in any one, because we evolved each of them for specific purposes.
That also brings up this, you know, very, I mean, it's challenging from the research point of view, because there's no real right, there's no like, you know, obvious healthy control. There's so many different shades of gray. And at the same time, you know, the way that we define these pathological circuits being stuck or too rigid is really a reflection of, a somewhat patient-centered approach. It's really up to them sort of to define. I mean, there's definitely the clinical side, determining whether it's maladaptive, but that interaction is really quite interesting.
As an outsider, I was just wondering if I'm hearing terms like cognitive flexibility and cognitive effort, and are these two different approaches to dealing with certain disorders? Are they competing? Are they different tools? Like, if you can provide some maybe basic definitions as to what these mean for someone who's not in the field.
As David was alluding to, I think these are concepts that are related, but I don't think wholly overlapping. So, and also there, I'm going to give like the typical scientist caveat of like, all of these things are really complex, and there's debate about the exact definition and so forth. But you can think broadly of cognitive flexibility.
Just to let you know, we do the same in higher education. We always talk about it's complicated, and then we go on to continue.
Exactly, it's complicated.
There you go.
But cognitive flexibility would be, I would think of it as the ability to adapt skillfully to situational demands in a way that doesn't keep you stuck in any persistent pattern that could end up making things problematic. So for instance, if you always drive the same route to work every day, and over and over and over and drive that way, and then there's a roadblock up on your direction to work, and you can't adapt to figure out how then to get to work. You just keep trying to, well, is there a way around the roadblock? Do you think I could park here and then like walk my same route to work? That would be, I think, what I think of as cognitive inflexibility. You keep trying something beyond the point when where it no longer works. Do you guys have, and then effort, I would think of as exertion towards a goal. So this is less the ability to say selectively, I've been trying this for a while, that's not working, I'm going to switch over here. I think actually this strategy would be better in this situation. Effort is sort of the drive or the exertion, either mental or physical, towards achieving some sort of goal.
I like your example because it made me visualize cognitive flexibility in the form of apps that we have on our phones that tell you going through this road is not the only way to get there, and their business model is to show you the other ways where you can get to where you
And to use that same metaphor, I would think of like effort as how hard you're pushing on the gas, right? So if you're very effortful and inflexible, you're just ramming into that.
Or you turn your phone off and you drive down the highway anyways.
And it might work sometimes, but at what cost?
There's some caveats that we're exploring, because the cognitive effort, you could say there's some very interesting aspects to it. Like for some people that are driving down the road, they have the nice model car and they don't have to press on that gas pedal a lot. Yeah. And the bicyclists, though, they have to put in a whole lot of effort for sort of the same outcome. And so the sort of perception of effort is sort of integral in that sort of concept of effort. And, one of the things that we're really interested in is sort of how these perceptions of effort really change, whether with treatment or pathology or, all these different sort of situations, so that we can understand what does it take to modify our perceptions of how difficult a task is. Because on the clinical world, we see patients and we say, if you really want to make some progress here, you got to do 20 push-ups, and some people say 20 push-ups, all right, I'll do 20 push-ups. That's not a big deal. And then some people will say 20 push-ups. I don't even know what a push-up is, and it's sort of, there's such a huge range there that there's, cognitive effort is really interesting. And some aspects of cognitive effort, can be easy for some people, and other aspects can be hard for the same people. So, there's a lot to that, that concept.
Yeah, I'm glad you brought that up, actually, because this is something that that I've been thinking a lot about, because the things that people say with anorexia nervosa do, for most people, are very effortful. It's very effortful for most people to say not eat all day, or to go run, 10 miles after like a long day of work. But clinically, when you see that, and when you hear the client's experience, they do not describe it as what most people think of as effortful, which is aversive, right? They don't think, that doesn't feel hard in the way that most of us would find that to feel hard. And actually, Alex and I, Alex is a co-I on a grant I just put in to explore this idea that for some people, effort might be conditioned to signal that they're going to get a reward soon. So like after getting rewarded many, many, many times for putting in a lot of effort, that feeling of effort actually might start to be less aversive and even enjoyable, which is really different than how we usually think of effort.
That really gets at how I tend to think about effort, which is like the balance between the rewards and the costs of whatever mental process you're engaging in. So any given mental process has some costs, and there are a lot of theories about what those costs might be. Is it an opportunity cost? Is it a metabolic cost, et cetera? And then some rewards, which are perceived, obviously.
Yeah.
And then the balance between that determines how fatiguing a given, activity is, how challenging it feels. And so I'm curious, like for you, do you think that an anorexia, for instance, I mean, I have a guess, but people overvalue the potential rewards from the effort, or are the costs just lower? Like breaking it down in those simple terms.
It's such a great question. It's something I want to figure out, because that would necessitate two different approaches, I think. So like applying this to anorexia nervosa, obviously people with this disorder really want to lose weight, right? That is the goal that they're working towards. So you could say that there's other higher level goals, like some sort of self pride, or like, recognition or something. But the short-term goal is to lose weight. And we know there's a good wealth of evidence showing that people with anorexia nervosa overvalue thinness. They'll tell you that when we look at brain imaging you look at somebody with anorexia in the fMRI scanner and you show them pictures of thin bodies, you'll see activation of the reward circuit. So we do know that this is a highly valued goal. And so the question is, does it feel just as effortful to them, but the reward is so big that it's worth, getting through the cost of, like, I feel like I'm going to faint and I can't think clearly, and my friends don't want to hang out with me because I make them feel really uncomfortable when they're eating? Or is it that actually something about the process itself becomes enjoyable, that something about, right now I'm fasting and I can feel in my body that is taxing, but something about that feeling feels good. In the same way, like an ultra marathoner will sometimes talk about, that feels strangely good, even though it also feels really bad.
Yeah, I mean, that has, just dramatic implications for how we approach therapeutic goals in the future. And, for instance, much outside of anorexia, should we try to develop neuromodulation that targets increasing the perceived goal or the increasing the reward, or at decreasing the perceived cost. That's what we're, ultimately trying to figure out across these disease states. Where is, in these sort of situations where cognitive effort plays a significant role, either as a barrier to therapy or as, the primary driver, where's the therapeutic target?
Absolutely. And on the flip side, with something more like anorexia nervosa, if it's simply that the reward is so big, you want to find a way to divorce weight loss from this intense reward, or have them target their energies towards another reward. But if it is that the cost of effort is so low, then I think that's a different approach, where maybe you want to, in some ways, get people more in touch with the time when effort is really costing them and when it's not worthwhile to keep going.
Right.
And I think those are they could be parallel approaches, but they might not both be necessary. I worry sometimes in the case of anorexia nervosa, because you see the weight loss and you see that they're doing this, that you target valuing the weight loss when actually it's a different process altogether.
It's interesting, the way you talk about, anorexia makes me think a lot about chronic pain. I mean, also we work on chronic pain, but, this sort of same, shortcutted pathways in terms of effort and sort of some avoidance, behaviors. It reminds me a lot of that flavor of chronic pain.
Interesting. Chronic pain is an area I know so little about. So that's fascinating for me to hear that parallel.
I mean, it's sort of always there in the background, but a lot of your decisions are driven by this sort of, constant thing, that becomes your entire life, and it wraps you up in it.
Mm-hmm.
It's an overvalued signal, basically, right?
Right.
Yeah.
Exactly. It's an overvalued signal. Right. And, that it pairs very nicely. I think that maybe that's just a superficial interpretation, but a lot of that sort of behavior really reminds me of that flavor of chronic pain.
Yeah, it's so interesting. It seems like there's so many parallels and different presentations of, you get your world, instead of a full life is, you have your work and you have your family and you have your interests and you have your goals you're pursuing, and you have, like, maybe you want to look reasonably presentable and all of that. And in each of these cases, it's like your world becomes just one thing, right? It becomes, I avoid pain, or I try to lose weight, or, in the work addiction example I gave, I work.
We're getting too close to home on the work addiction problem, but I
find when I talk about it, my colleagues get fascinated and also a little uncomfortable.
Neurosurgery is not a good place to talk about work addiction.
It might be the place to talk about.
That's true. That is very true. Yeah, I totally hear you. We're not going to hit there too hard today.
Annie, one of the first times I heard your name was pretty shortly after I came to the U. I was in a seminar with Dave Reddish was there, and it was Joe Cable. He was giving a talk, actually. And at the end, we were talking about delayed discounting. And he said something like, with just this sparkle in his eyes, about how, it might be that people with eating disorders, and maybe he was talking about anorexia nervosa, might be one of the only groups that displays, extended, delayed discounting curves. And then he was like, and we'll see, like, Annie has that data. And he was I could just tell he was so genuinely excited by that.
Yeah.
It was really, just inspiring to see. And I just wonder if you, if you could say a word or two about how that interaction, and just in general your interaction with the computational psychiatry community, has like influenced you, how you have influenced them, like how that's evolved.
Yeah, I feel like that that worked out so well. So prior to the psychiatry department getting really paired up with the neuroscience department and computational psychiatry, I had started, obviously the idea of computational psychiatry, computational neuroscience, informing psychiatry started to become something people would talk about a few years back. And as I started to learn about it, the thing that really appealed to me is a lot of these disorders, and I would say anorexia nervosa is definitely one of these, where it's so complex, and the tools, the mathematical tools and the methodological tools we've been using are so blunt. I would say, we give people a questionnaire, even some of the neurocognitive measures we give people, it's like, did you make a good or bad decision? It's like, well, if you made a bad decision, how? And if you made a good decision, how? And so what was really appealing to me about computational approaches is that it gives you much more of a fine-grained, nuanced understanding of if something goes wrong in behavior, how did it get there? And how did the different pieces of what got you there interact? So instead of, for instance, just saying, people with anorexia have too much control. It's like too much control under what circumstances, interacting with reward in what way. And I felt like computational psychiatry had a good beat on that. And Dave Reddish had come and given a talk for our grand rounds, and he talked about these different decision systems that could influence behavior. And one of the things that was really appealing to me is he was talking about how different decision-making systems can influence different stages of illness, and they can also sometimes be adaptive and sometimes not. So what I was talking about in some of our findings of that very efficient, we call it a rule-based decision system, of overutilizing cognitive control circuits in a very fast way to make very rigid decisions. As we talked about, that can be very adaptive in some situations and not in others. And there's also some idea in anorexia that might be an end stage presentation, but earlier stages may be more of this reward driven presentation, where like we were talking about, the reward of weight loss early on is the driving force. And then later on, it becomes more of this kind of rule-based, efficient cognitive system that takes over. So anyway, because of the complexity of the approach that he was talking about and that I knew computational psychiatry could bring in, we ended up connecting up. And I think what David really found appealing was this idea that this idea that we were talking about, where in anorexia nervosa, we might see a presentation that manifests in other disorders through the same dysfunctional decision-making system. And if we can fix that decision-making system, can we fix not only this disorder, but a bunch of different disorders, like maybe OCD or something like that share something similar. So that's sort of my long-winded description of how I got kind of connected up with computational psychiatry.
That's perfect. Yeah.
Perfect. Yeah.
Annie, with the societal cultural nature of the reward and punishment system associated with eating disorders,
Yes.
is any of the work in your field focusing on what happens around the person, the support system or lack of support, and how to manage that, and what kind of tools and approaches to even deal with that and manage it?
Yeah, it's a great question. It's clear that environment plays a role. And I guess my answer is in two parts, that in some ways the field has over-focused on what you're describing, the environmental features, and in some ways it's under-focused on it. So it's over-focused on it in the way that, when you hear anorexia nervosa talked about, it's usually, young women who want to look like the models and stuff like that, which is, not really what you see when you see it in clinic. And in the way we've under-focused on it is that, with the shift towards brain science, we sometimes neglect the outside influences. My hunch is, how I talked about how the same sort of mechanism can lead to different presentations, right? So again, I'm just going to take my favorite example of work addiction. That's going to make everybody squirm. But say they are the same thing. Why would you have anorexia over here? And why would you have work addiction over here? And I think that has to do with what your environment shapes you to value. Okay. So I don't think it's probably an accident that anorexia nervosa shows up more frequently in women. I think it's because there has been a lot to say that is a societally held value for that subset of people. But I think the thing that gets you to over-focus on one goal or another, that thing, I think could be shared.
Interesting. The basic question is, if, as a society, we did not have put this value on weight loss and, thinness, are those same people susceptible to, work addictions or other things like this? Or is this really, a product of, society placing extreme value on things like work or thinness?
Yeah. It's probably an interaction of both, right? I mean, I think if you take those same people who go on to develop anorexia nervosa and you took out that societal value of thinness, there would probably be a different manifestation. That's my guess. Interestingly, anorexia nervosa has been around for a long time and shows up in all sorts of different cultures, including those that don't necessarily place that value. But when you hear the narratives of the experience, for those people, it focuses more around things like other societal values, right? Like if a society values sort of like a self-denial kind of value, that will be the thing that's sort of the narrative of why they're doing the restricting. Or if it's more around just like control as a value, that's what it's wrapped around. So I think the part that probably we need to pay attention to on a societal level is valuing those certain goals to the point where we're willing to accept the pathology that comes along with it. So in certain, for instance, in certain work settings, are we willing to accept that if we so strongly place value on productivity, that some people's mental health will suffer? And that's a big question.
I think my wife is asking that question right now.
That is a tough comment to follow.
Yeah, so we can all just ponder on how to reshape society.
Yeah, my mind is going to an extreme when it comes to that, because as you were talking, Annie, I was looking up, because I knew about this phenomenon. And I'm not saying they're the same. I don't know much about it. I'm not saying they're comparable, but I was looking up information about cultures that go and societies that go to the other end of the extreme of that spectrum by force feeding females before marriage in preparation, because the value there is on weight, adding weight rather than losing weight. to the point that some cultures and places have that practice of force feeding girls at a certain age in order to prepare them for marriage. So it's fascinating to think about the interaction between what's innate and what's in our brains as far as decision making goes, but also what's outside of us in the forms of rewards and punishments and values in society that cover a whole spectrum of extremes, when it comes to what's out there. So,
right, we bring into it how much, these processes of how effortful, how much effort we're willing to exert, how much delay we're willing to tolerate for our goals, how flexibly we can approach those goals. Those are the things that we bring in, but what those goals are and that we choose to attach to, that I think has more to do with what we learn to value.
Yeah. Interesting.
Well, thank you so much for coming to chat with us today. Hopefully it was. I thought it was fantastic discussion. It was really interesting. Definitely a pleasure.
Thank you. Yeah, I really enjoyed it. You allowed me to rant on my favorite subjects, which I always appreciate. No, and it was fascinating to hear your take on the work you're doing with cognitive effort and cognitive flexibility. So I'm really looking forward to hearing more about that in the future.
Yeah, more discussions to come.
Yes. Well, thank you so much for having me.